I'm a radiation oncologist here at Mayo Clinic. Hello, my name is David Routman, and I'm excited for the opportunity today to talk about AI in practice, auto-segmentation tools. I'm a radiation oncologist here at Mayo Clinic and appreciate the invite to be a part of this joint conference with the Saudi German Hospital in Cairo. This is my disclosure, which is not relevant to this talk. So I'd like to start by asking a couple questions. Number one, do you use auto-segmentation in clinic? And number two, do you use auto-segmentation to delineate target volumes, like the GTV or CTVs, or just for organs at risk? And even if you don't use any auto-segmentation, do you think it's the job of a computer or a human, a radiation oncologist, or someone else to generate these target volumes? We'll think about that as we go through this talk. I'd like to start by going through some organs at risk, thinking about guidelines and number of structures per case, time considerations and contouring, and then the importance of accurate delineation, moving on to auto-segmentation with the overview of OARs, brain metastases, as well as primary brain tumors. So the European Particle Therapy Network, which is a working group of ESTRO, known as the EPTN, put out consensus guidelines for CNS cases about the structures that were important to contour, and they provided a very nice atlas with definitions, supplementary data to this publication, as well as some figures referencing the structures to be contoured. And you can see they do things like subdivide the brainstem and the cerebellum, provide the rationale for contouring the pituitary, and give definitions of the optic chiasm. But this is only one atlas, and other clinical trials have their own atlases. And what's more is they may define the structures to be contoured as different from what another working group or another consensus guideline recommends. And this can lead to differences when comparing across trials. Additionally, there's overlap of CNS with head and neck, and we see that head and neck consensus guidelines may include some of the structures in CNS, but may have slight differences in their definition, as well as they may include additional structures, like the semicircular canals, that are not included in the CNS definitions. So there's heterogeneity in terms of what structures should be contoured on any given scan, as well as the definition of those structures. This is evident in this example, where at Mayo Clinic, these are the structures that we contour in our standard CNS case. These are not necessarily listed out, for instance, the parotids and the cord in the EPTN framework, but nevertheless, that may be because they expect the cord to be contoured kind of in a head and neck setting. But structures that are recommended by the EPTN that we do not contour at Mayo Clinic include the cerebellum, anterior and posterior, the anatomical ant and post divisions of the hippocampi, as well as subsegmenting the brainstem. Now, whether or not these structures as a substructure really make a difference in terms of dose distribution, we don't know, but we would have to contour them likely to be able to find out. And while it's tempting to add another structure to a template to contour, we have to realize that there are real costs to that in terms of time. The mean time required to manually delineate all 34 OARs in a clinical setting based on this consensus guideline was 88.5 minutes. So we're essentially looking at an hour and a half just to delineate these 34 OARs. When we looked at our own data in head and neck, there was a working group at Mayo that curated 42 OARs to be generated for auto-segmentation, and you can see a representation of them here. It took two physicians who contoured the gold standard 34 cases around 4 hours to segment out all of these OARs. So that's a ton of time per case if you're really going to detail each of these structures as potentially recommended. And that's not enough, because now the EBTN has recommended additional structures like the amygdala, fornix, macula, optic tract, periventricular space. And some of these structures have a pretty good rationale of why we should contour them in terms of their importance in function, such as the amygdala, or in their sensitivity to particle therapy, such as the periventricular zone, that has shown sensitivity to end of range, in particular with protons. That's going to add even more time. So in summary, segmentation of OARs, especially for CNS and head and neck cases, can take time, 1 to 4 hours per case. This does not include the case review of the patient situation, image registration, target definitions, entering a planning template, or a review of the treatment plan. But we know that these structures are important. So this is a multi-institutional study within the US, CC001, which was led in part by Dr. Brown and Mayo Clinic. And these results showed that avoiding the hippocampus by giving a D100% less than 9 gray and a Dmax less than 16 gray resulted in better neurocognition compared to standard whole brain radiation therapy. Even the parotid gland should be contoured in whole brain radiation therapy. Higher doses to the parotid, whether intentionally or by not considering it in terms of a lack of contouring, such as a V20 less than 47% or more than 47%, resulted in differences in xerostomia, as well as patients being more or less bothered. The brachial plexus is another example. Many groups in breast cancer or in head and neck cancer don't necessarily delineate the brachial plexus, but we know that years after treatment, late toxicity can develop. It may take 4 to 5 years post-treatment, but symptoms can be progressive in terms of paresthesia, pain, and weakness, and that can have a significant impact on quality of life, and it's likely underreported. If we don't contour the brachial plexus, look at our dosing considerations, and follow patients, then how will we know about this brachial plexopathy? So accurate OAR contouring is critical for treatment, including decision-making regarding the trade-offs in dose and for understanding outcomes. Thankfully, we have great consensus guidelines, as mentioned, for things like the hippocampi, and this has been done prospectively, multi-institutionally, but nevertheless, for a structure that's 3 to 4 cc's, significant variation in human delineation is there. And we see that. These are multiple observers at our institution contouring out the hippocampus. And you can see while the staple definition likely has good agreement on what would anatomically be the hippocampus, that there's a decent amount of variation. And that may be different when we look at certain MRIs versus CTs. And you can see the optic chiasm similarly here. And so Doug Mosley, who you heard from earlier, has created a program where he can take these contours, represent them in space, and then overlay 2 different ones for comparison, or even multiple ones, to show that there's significant differences in the ant-post contours for the optic chiasm and ant-post, as well as medial-lateral for the hippocampi. If we look overall at a number of different scans in hippocampi that are contoured, as well as optic chiasms, what we see is that the quality of the MRI that's registered makes a huge difference. So for those scans where a high quality MRI was available, there was less variation in the dice coefficient, and the overall median dice compared to the gold standard was higher versus lower quality MRIs. And that was true for the hippocampus as well as the optic chiasm. So substantial variation exists human to human in terms of contours as well as in structured definition, atlas to atlas, and therefore segmentation can vary across studies. And better guidelines, better consensus guidelines that unify all of these structures, as well as ways to decrease our time in segmentation, are needed. And that's where auto-segmentation comes in. And so we'll focus on it for now. I asked ChatGPT what is artificial intelligence, and it said AR refers to the development of computer systems that can perform tasks typically which require human intelligence, perception, reason, learning, decision-making, natural language processing. AI systems are designed to analyze and interpret complex data, and so segmentation is a good task for a machine. I asked ChatGPT to provide an overview of artificial intelligence applications within radiation oncology with citations. And you can see it discussed treatment planning, dose calculation, image analysis, and quality assurance, all of which are important and likely good uses of AI in transforming our field. But nevertheless, the citations did not go to relevant articles. And I tried to correct the ChatGPT by saying these are mistaken links, and it still gave me links that don't make sense. So ChatGPT can have hallucinations and errors, and auto-segmentation can have hallucination and errors in a way that a human normally may not make a mistake. And so the modes of failure are different, even if they happen less often. And so we need robust quality assurance in place. We also have to think about, is what we are defining here really artificial intelligence or just augmented intelligence? Is the computer seeing things that the human doesn't? I like this example because with deep learning, I would say yes, there are some things that the computer is picking up on that the human is not. And so this example is from the Mayo Clinic cardiology group where they looked at millions of ECGs, and they were able to look back at patients that eventually had an ECG that had AFib or A-flutter, and they were able to pick up that AFib or A-flutter likelihood based on normal ECG preceding it, which a human was not able to do. And if they had multiple ECGs before the event to analyze, you can see that they had an AUC of 0.9 for being able to predict the development of AFib on subsequent ECGs. They also let the computer know whether the training ECG was a male or female. And then they fed a validation in the test cohort back to the ECG and had it define whether or not the patient was a male or female in terms of biologic sex. And it did a better job than any previously defined features or than a human can do. So a human can't look at an ECG and necessarily predict AFib or sex in the same way that the computer can. And so accurately predicting sex and age in most individuals is a breakthrough and probably artificial intelligence because it's a biomarker property that otherwise didn't exist. And we see that if we apply this to men that were undergoing androgen deprivation therapy, that their change in the way that the computer estimates them being male versus female is present. So men receiving ADT had a lower male value. Now exactly what that means in terms of outcomes we don't know, but it shows that the ECG is picking up on hormonal changes that are present based on the receipt of ADT. And so this is a novel variable that can be applied to other data sets. Now there is a trend where intelligence may be defined as the ability to learn and perform suitable techniques to solve problems and achieve goals in an ever-varying world, and where at the same time a fully pre-programmed factory robot is flexible, accurate, and consistent, but not intelligent. And so as we move forward in AI, the things that we say that is intelligence may be the things that we classically think about a computer not being able to do. And then when it doesn't, we say, well, that's not actually intelligence. Meaning that in the past, we didn't think that a computer could beat a human at chess. And then after that, we said, well, there are a ton of moves, but we have a basic infrastructure, and the computer can have more memory of prior games. But Go is something that can't be solved. And now, Go is solved. And so we're kind of marching one task to the next and seeing just what is the limit of what we would consider this intelligence. So AI is characterized as a collection of algorithms that perform tasks correlated with human thinking or intelligence with machine learning and deep learning as subdomains. And this is another example that you may have played around with, DALL-E and DALL-E 2. where you can give text and generate an image, and this was an image I generated of the Saudi German hospital in Cairo, an auditorium undergoing a lecture where the majority of the participants were falling asleep. And this is what the computer drew up based on that text. So computational approaches such as neural networks are giving us the ability to consider complex data sets, and we don't have to have pre-selected discrete data. And there are even examples that we can play around with to understand what are the inputs, nodes, and outputs of a particular model. And there are guidelines that have come along. Given the complexity of AI, the potential for biases that exist, and the risk of implementation, but also the benefit, we need working groups to inform us how we maintain quality while saving ourselves time and maybe improving patient care. So, deep learning in summary may allow for usable signals not otherwise readily identifiable in the data, and machines fail in ways humans do not. So, quality assurance is necessary. Moving on to auto-segmentation, then, there are methods by which we can evaluate the segment that a computer delineates in comparison to what a human does. And the dice coefficient is one of many different ways to do this. It ranges between 0 and 1, and it can be thought of as a quotient of similarity. So two structures that are exactly equivalent would have a dice coefficient of 1. That same EPTN group looked at AI segmentation for these structures that they recommend contouring and showed that there was a pretty good dice overlap between the auto-segmentation and humans. And what they saw is that the median time required and the mean time required went from 88.5 to 15.8 minutes, saving more than an hour of the physician time. And most structures required fairly minimal adjustment in red, as you can see. So the optic nerves, the brainstem, or the hippocampi or cerebellum or brain may have required some adjustment at times, but on the whole, a lot of structures were just fine as they were. We looked back at our gold standard curated data set in comparison to clinical contours. And so this was a case that there were 34 or 35 head and neck contours that were all done over time to meet our gold standard criteria. And we compared that to what the patient had turned in clinically. And we saw that there was a lot of variation by structure, and that overall the clinical acceptability was in the 0.7 range. That if you got to a median of, say, 0.7, that's kind of where clinical contours live compared to gold standard and acceptability. And we use that as reference criteria to compare various vendors. And what we saw was that many of the vendors performed at or near the clinical acceptability. And that was especially true if we only looked at the vendors that had overlap in the most common structures, where clinical contours still won out and had the highest median, but vendor 1 and vendor 6 were not statistically different and likely acceptable. Nevertheless, you can see in the X's here that they did not do many structures that we would commonly want, like the cochlea. And so there's variation across these vendors in terms of the structures that they contour, as well as in the quality of the segments that they contour. But you can see that many of the vendors are approaching clinical acceptability. And they're starting to offer elective nodal volumes. So, levels 3 and 4 and 5 and 6. These look pretty good in terms of segmentation and can help save time by being able to click on or click off these nodal segments. So vended solutions vary in the number of OARs contoured and may differ in the standard definition and summary, but some may perform nevertheless at a clinically acceptable level and are likely ready for routine use as they're FDA approved. Auto-segmentation can also be applied to target definition. This was a great example where they looked at over 1,600 patients and developed a model of segmenting out brain metastases and had Dice coefficients that were all above 0.9 with a high sensitivity and specificity in each case. And it allowed for evaluation of automated treatment response. We can say, is this a new lesion? Has it gotten bigger or smaller over time? And that can also be very helpful at evaluating data sets. So this is promising for brain metastases. What about for glioma? A group out of Yale has implemented a pipeline where after the scan is done, it is sent out to have segmentation performed as well as extraction of radiomic features. So now, not only is the tumor being segmented, but radiomic features are being extracted so we can start to see how certain features are associated with outcomes and may influence decision-making surrounding patient care. And the total computation time was about 5 seconds per case for this. There are other vended solutions that are coming online that offer segmentation for tumors. Even an FDA-approved AI product for high-grade gliomas. And so I think that we will see that more and more the delineation of targets is also done by computers, but we need strict quality assurance and human oversight. This is another example looking at various data sets and different types of configurations in terms of the AI to segment glioma. And we can see that the UNets on a robust data set contouring the whole tumor do a great job, kind of in the 0.9 range. So AI auto-segmentation of targets is generally reliable and allows for additional extraction of information, though much more work, as noted, is needed. So that's a very quick overview of auto-segmentation to say that yes, products are here for OARs. They do a pretty good job. We need to ensure their quality and make sure that we have a good and robust human interaction and workflow. Targets are coming online in terms of metastases as well as primary brain tumors and elective volumes. And these are going to be time savings for the clinician. Thanks for your attention. I'd be happy to take any questions and feel free to reach out.